All right, so thank you everyone for joining this afternoon. So as Martina said, this is really where we are hoping to help you navigate the opportunities for diabetes research within the Horizon Europe and the newly released work program for 2026 and 2027. So I will slowly go ahead as people are dropping in just to go over the agenda for today. So today's speaker will be myself from BreakthroughT1D, working as a program officer for European research. Also from BreakthroughT1D towards the end, we have for the question and answer discussion, Carmen available, who is the director, European research at BreakthroughT1D. We have Cameron Keegren with us from IDF Europe, who will go over the lived experience and involvement of people living with type 1 diabetes and type 2 diabetes in research projects. And also we have Sabine that will summarize the key takeaways for today, Director for Policy and Strategy at IDF Europe. But we're really hoping to give you a clear picture of why Horizon Europe matters for diabetes, and give you an overview of the structure of Horizon Europe, and then importantly, help you to identify some key calls in this current work program. Cameron will go through the involvement of people with lived experience and how important it is to engage with people living with diabetes and the patient organizations early on. I will come back and go through a little bit about the evaluation and how to build a strong competitive proposal. And we will end with some next steps, key takeaways, and hopefully an interesting question and answer session. So here I really want to emphasize why Horizon Europe matters for diabetes research. So both type 1 and type 2 diabetes fits very well with the Horizon Europe program, and especially for this current work program, even though many calls are disease agnostic. And it's really important to successfully position diabetes, whether it's type 1 or type 2, within the non-communicable diseases, but also relevant for the cardiovascular health plan that is now a priority in EU. Also, the increased risk that people living with diabetes suffer from for cardiovascular disease. But also importantly, really a chance to benefit from digital health, personalized medicine, and AI. So our key message here is that you don't really need a specific type 1, type 2 diabetes labeled call to win Horizon Europe funding, and that we can really utilize the strengths that we have. I mentioned to just positioning it. We have very innovative science with also a good translational impact, given that we have strong biobanks, cohorts, registries with real world data. But we also have, importantly, a very strong patient community with the patient-centric approach. It's aligned well with the priorities within EU. It gives the chance also for sustainability in developing diagnostic tools and a therapeutic pathway. So going more into the structure of Horizon Europe, today we'll go into cluster 1, which is in pillar 2, but just saying that in the other pillars, we have the ERC and the Marie Curie, we have the Innovation Council in pillar 3, but here is really the focus today of cluster 1 and the health. But overall, the areas of intervention for Horizon Europe are health throughout the life course, environmental social health, as I mentioned, the non-communicable and rare diseases, infectious diseases, and again, important for diabetes, tools, technologies, and digital solutions for health and care, including personalized medicine and healthcare systems. So in terms of the call cycles and the deadlines for cluster 1 health, they are divided in single stage calls. There is single stage calls both for 2026 and 2027. And then there are the 2-stage calls. So just to say some key facts, the single stage call, as you can tell from the title, is a single submission, a full proposal from start. And it's really best when the concept is mature and you have strong preliminary data. Whereas for the 2-stage call, there's a short and then a full proposal only if invited. And this could be more suitable when there's a complex exploratory topics, there is likely to be high competition, and you have that opportunity of shaping the project more if you're invited for the full proposal during that second stage. So here are the dates for that, and they will come up also when I present the key calls that we have identified. So here's a QR code if you want to get the whole work program, the PDF. But I will now go through, I believe, 6 of the key calls that we have identified, both for the entire diabetes of both type 1 and type 2, which is relevant for, and where IDF Europe would like to be involved. Whereas from BreakthroughT1D, our focus is, as you know, type 1 diabetes and research that are aligned with our research strategy. So some of these calls are applicable to both of us, where we like to be involved, and some more for maybe targeting type 1 diabetes. So the first call is really related to the importance also for the cardiovascular health plan. The goal is to really advance sex and gender specific understanding of cardiovascular disease and how it can enable that you have a tailored risk model, improving prevention, diagnostics, and treatments. It's a single stage call that is for this year. The budget is 6 to 7 million per project with a total of 39.3 millions. And it's highly relevant both for type 1 and type 2 diabetes, as women experience excess risk of cardiovascular disease compared to men. But it also gives an opportunity for the diabetes community to really benefit from integration of biobanks, cohorts, and real-world evidence. The next identified call is in innovative healthcare interventions for non-communicable diseases, NCDs. And here they're looking for early stage clinical trials that are transforming intervention targeting major non-communicable diseases. Only specific one mentioned, but it does include diabetes and cardiovascular disease. It's a 2-stage call for next year. But the proposals should, besides some requirements for what kind of data you have before, it should also consider sex and gender. It should use and or develop technologies, for example, AI or wearable technologies, and really see how you can use existing data, biobank, registries, and cohorts. Importantly, they're looking for the proposals to engage with all relevant stakeholders, so both patients and patient organizations, and they're also looking for a health economic assessment and a real-world data analysis. The next call is in new approach methodologies, NAMs, to really advance biomedical research and regulatory testing. And this could be relevant for the development of advanced platforms, such as induced pluripotent stem cells, organoids, organ-on-a-chip systems, high-fidelity in vitro assays. These are essential tools for T1D pathophysiology and therapeutic discovery. It's a single-stage call that is for this year. The budget is 5 to 8 millions with a total of 49 millions. And then we go to the next call, which is in follow-up funding, where they're looking for leveraging previously funded EU-funded collaborative research in regenerative medicine. It supports the continuation of high-potential EU-funded research, and this could be a major opportunity for regenerative approaches in type 1. And here I mentioned some of those projects that could maybe benefit from this call topic. Going into the next one, it's for 2026. It's a single stage call looking to fund one European network of centers of excellence for ATMPs. And this could really build a coordinated ecosystem for ATMPs for future type 1 cell therapies, looking for a renewable cell source for type 1 to really cure the disease. Here we're going to the next one, which is a 2-stage call, looking into how we can use AI to discover new biomarkers to predict both the progression of the disease, but also the treatment response. And this could be really a transformative pathway for diabetes care, both for type 1 diabetes and type 2 diabetes. Then the next one is in bioprinting. It's for 2027 and it's in the second part of that year. Really, it could be cutting edge bioprinting technologies to engineer functional tissues. And this is highly relevant to next generation beta cell and islet replacement strategies. So overall, these calls that I presented, diabetes is highly competitive in this work program when you frame it as a chronic disease with lifelong burden. It has high cardiovascular risk, and it's a model disease for personalized and digital health innovation. So with that, I will hand over to Cameron, who will go into the importance of people with lived experience for consortia.
Great. Thank you so much, Hilda. So my name is Cameron Keekern, and I'm a project coordinator with the International Diabetes Federation for Europe. So if you want to move to the first slide. So we've talked about the different calls that are becoming available or upcoming. And I suppose my job is to maybe take you through how co-creation with people living, in this case with diabetes, but in general living with non-communicable diseases, why that matters and how we can do that. And I suppose if you look at the diagram on the left-hand side, we look at lots of different ways or different stages of research where co-creating with people living with chronic conditions or non-communicable diseases might be relevant. In terms of research and development, driving research, the research agenda and the prioritization. So when we think about that, sometimes as researchers, we have lots of ideas about what we would like to study and what we think might be interesting questions to answer. But that's not necessarily reflective of the experience of people living day to day with diabetes or with other NCDs. And so adopting and involving people from an earlier stage means that you get true questions that are important for people living with these conditions, but also you get more meaningful research out of it at the end. You're understanding some of the unmet needs within those communities. And then you're also refining some of the endpoints to be more person-centered and getting to that or closer to that personalized medicine area where a lot of research has been, I suppose, moving towards. When we move into more kind of looking at clinical trials and preclinical studies and kind of later stage research, we know from research that when you co-create projects with people living with the condition that you are studying, it does have a dramatic increase on the recruitment and retention of those into the studies with improved trial designs and protocols alongside enhanced targeting of the community that you are trying to work with. Very often when we're designing recruitment materials or materials for communication or dissemination, if that's done without the input of people living with diabetes or the specific non-communicable disease that you're looking at, it very often doesn't hit the mark for that community. It doesn't necessarily entice people to come along. It doesn't feel like something that they can be a part of. So including lived experience at that point allows us to create better designed tools and better designed recruitment materials. It also allows us to address some challenges with safety and ethics before they arise by asking questions of people living with the chronic condition of themselves in terms of how they feel about different elements of the clinical trial, how they feel it might land, and what they think might need to be done to improve the feeling of safety of it, the feeling of ethics of it, and overall the benefit of this particular work. So there's lots of ways by including people living with diabetes, how that enhances research. But on the right hand side, I suppose sometimes it's a little bit tricky to really figure out how do we do this and how do we do it well. And the diagram on the right hand side talks about co-production and I suppose how do we co-produce across a research project with people living with diabetes or with other NCDs, depending on what you're looking at. And what we're looking to do is, I suppose, on the outside of this diagram, you'll see lots of different kind of sections. So the one I'll focus the most on is around prioritizing relationships. One of the biggest things that we can do when we include people living with different NCDs, and in this case, diabetes, is to develop some of the relationships that we have to break down some of the barriers between researchers, maybe the budgets, the people living with diabetes, and how do we have conversations where all expertise around the table is valued and brought together to find a common ground and to design a project that meets the research goals of the team, but also meets some of the research questions that those living with diabetes would like to see answered. Um, around building capability, sharing power, co-discovering, co-designing, and having a space where you lean on the community to answer some of the questions maybe that you're not aware of, or to bring a perspective that maybe as a researcher you don't always have if you don't live with the condition itself. Next slide, Hilda. And we wanted to go through some examples of how IDF Europe and other groups have come together to support co-creating this process with people living with diabetes from some of the European projects that we've done. The first one I'll speak about is Trials at Home, which was a pan-European public-private partnership that looked at the feasibility of doing, I suppose, decentralized clinical trials or community-based clinical trials. And the example that they took at the trial that they wanted to do was a trial looking at improving healthcare outcomes for those living with type 2 diabetes. And so IDF Europe came on as a partner, and we helped to co-create a patient expert panel which convened a number of people living with diabetes or supporting those living with diabetes. In this case, a mixture of type 1 and type 2, but this project focused mostly on type 2 diabetes and brought those individuals into the project to be a voice for what the community was looking to understand. They provided input on key deliverables of the project, different choices of technologies, design, the protocol, communication. How should that look and feel to people living with type 2 diabetes in the community that they were looking to recruit into this clinical trial? It looked at giving input into the different key stakeholders and opinions that were important. Again, recruitment, as I said, communications. They also looked at the training materials. So in terms of the clinical trial aspect, when they were designing the materials for the participants in terms of training them in relevant aspects of the trial, our patient expert panel gave their input in terms of how those training materials felt. Was it clear? Was it understandable? Was there something that could be changed? And gave key direction in terms of how that looked for the end product for the participants who were part of that trial. And also around translating some of that work. So quite often in this project and in others, the lived experience partners can help you to translate some of that science into the community and build better trust and retention within the work that you're trying to do. Um, the other project that I'll talk about on this slide as well is the ILET project around how do we improve the awareness of cell-based therapies for those living with type 1 diabetes. And in this project, we brought together young people from across Europe who lived with type 1 diabetes, young scientists and other senior scientists who are working in a research center in Munich in Helmholtz, the diabetes center, on how we could translate some of the work that was happening there and disseminate that out into the wider public and into the wider diabetes community, whilst also providing a space for capacity building for the young researchers to know more about people living with type 1 diabetes, and for the people living with type 1 diabetes to know more about what was happening in the research world. And so we did a lot of work around education and awareness raising, and again, the identification of priorities for people living with type 1 diabetes and that capacity building. And I'll talk a little bit more about the ILET project specifically on a slide further on. And the last study, the recognized study, again, having people living with diabetes who gave their input on informed consent, the study information leaflets, the design of the clinical trial, and also the communication and dissemination. But overall, these examples, I suppose a lot of what brings them together is that it helped us to build trust within the community that these were projects that participants wanted to be a part of, that there was a strong sense of that the voice of the community was embedded and built into the projects, and that those living with diabetes had an equal say or as much of an important say in the research questions that were being asked and the things that were trying to be done to improve their quality of life, that they were at that table having those conversations as well. So the next slide. But it's not, I suppose in that slide, we make it sound a little bit easy of we brought people in, we did things and it worked really well. I think it's important also to think about what needs to be considered when you are co-creating different processes with people living with diabetes or living with other NCDs. And if we look at it from the principles, it should start early and be comprehensive. There's no point in designing a project, submitting for funding, and then coming back and saying, now we'll include people living with diabetes and see what they think, because at that point you're looking for feedback as opposed to co-creation. And we challenge people to move beyond consultation and into co-creation, and to take that kind of step to have those conversations as early as possible about what are the key research questions that we should ask, how do we want to address them, how do we want to recruit, who do we want to be involved. recognizing that people with lived experience are experts in their own domain as much as people who have expertise in research are experts in their own domain as well. And it's about building a team of complementary expertise. So bringing people in living with diabetes to really understand what does it look like day to day to live with type 1 or type 2 or another form of diabetes, and how does your research question fit in to that daily experience? And that engagement must be representative. And that's the one of the big challenges we have within patient expert panels or lived experience is ensuring that we truly reflect a wide range of experiences, both at the individual level and also at the patient organization level. So it's important to look at how do we recruit people living with diabetes or with NCDs, but then also how do we recruit and engage with patient organizations who might help with some of that inclusivity and in representation, and ensuring that we have a diverse range of voices around the table when we have these conversations and these research questions. Moving then on to ground rules, very often when we bring, I suppose, a new cohort, and lots of projects are now working with people living with NCDs and living with diabetes. And I think the vast majority of projects will talk about how communication needs have to be adapted when you bring in lots of different people into one group. And looking at how do we speak and how do we talk about the different research that we're trying to do. Are we using a lot of jargon heavy language? Are we using a lot of medical language? Are we sure that everyone is understanding the conversation? And so being prepared to adapt how we communicate, change the clarity of expectation, and to respect where everyone's coming from. So to respect people's backgrounds will be different, people's experiences will be different, and also people's thoughts and opinions will be different on what's the best approach going forward and how do we come to a common ground. Really important to ensure that we close feedback loops, that we don't just go to people living with diabetes and say, what do you think about this? And never go back and say what we've done with that information or if we've taken it on board. Even if the outcome is negative and saying we can't take that forward, going back to a lived experience panel and saying, we heard you, we listened, this is why we can't do this right now, and this is what we'd like to do in the future. So whether it's positive or negative feedback on what's happened afterwards, to make sure that we go back and close off that feedback loop, and to acknowledge the contributions made by people living with diabetes in your project. So including them as named authors, for example, on research outputs, including them as people that are listed in conference presentations, in reports, ensuring that we don't just have an anonymous kind of patient experience group, but we actually name them as individuals. And ensuring from the outset that we set clear rules of engagement. What's the expectation from both sides? What do you expect the people living with diabetes to do, and what do they expect you to do? Notwithstanding that that's often quite a living dynamic space, but having some kind of clear guidelines to frame that beginning or that initial step, we find is really helpful for retaining people living with diabetes as part of projects. And then looking at resources. So looking at how do we budget or cost for items that might be related to patient experience panels. Very often we don't necessarily include these as budget line items or in any sort of great detail. So it's important to look at how are we going to compensate the time of the people that we have asked to be a part of our group. How are we fairly and adequately compensating their time? How are we compensating some of the admin responsibilities that might need to go into supporting a group like this? How are we compensating maybe a patient organization that might need to be on a leadership capacity within this particular work? But also, how are we considering things for dissemination of some of the work that they've done and some of the, I suppose, key outputs? Is there a budget item to bring people with lived experience to the various different events? Is there a budget item for bringing them to mid-year, end-of-year meetings, to conferences, so on and so forth? So it's an extra consideration that we would definitely note to take care of. And it also includes, and this is something that is also quite often left out. It does also include the training needs and time of researchers. So it's also about building in what training or support or guidance will we need in order to make this efficient and effective, but also how much time do we need to build into the budget for researchers or admin or others to be supporting the lived experience side of this work as well. I think this is my last slide, this next slide. And so we wanted to just, again, pull back in the ILET project, which, as I said, was looking at cell-based therapies for type 1 diabetes, but from a perspective of how do we translate some of this science. And it's how we involved, I suppose, lived experience from proposal to practice. And so from the outset of this project, it was decided that there would be a lived experience element to it. As I said, Eilish aims to develop stem cell derived cell therapies for type 1 diabetes. But we wanted to have a space where the researchers who were working on these projects learned from young people living with type 1 diabetes, what did that actually mean and look like? We wanted to do some co-design of workshops and trainings from both the young people living with type 1 diabetes, but also the young scientists who were working on it to ensure that there was I suppose, a symbiotic relationship between both in terms of there was an understanding from the researchers why they were doing the research that they were doing, but also an understanding from those living with type 1 diabetes how research works. How do we get from an idea to the point of a research project or proposal coming to life? And in October of 2023, I believe, or 2020, yeah, 2023, I think, maybe 2024, I can't remember the exact year, we brought a number of young people living with type 1 diabetes to this research center in Munich to learn and to see firsthand what is stem cell based research for type 1 diabetes in its entirety. What does it look like? And again, what that did was it opened up the eyes of young people living with diabetes as to how the research process worked. They could shape some of the questions that the young researchers were having. There was a discussion from the young researchers about what they were interested in and how that aligned or didn't align with what the research interests of young people living with type 1 diabetes was. But ultimately, everyone walked away from that with an understanding of what each side of that research project does. What does it mean to live with type 1 diabetes? What does it mean to be a researcher in type 1 diabetes? And how do we work together? And a lot of the questions that were asked there were changing some of the research questions that were being discussed. Actually, this might not be something that's super interesting, but this side of it is. And so what that allowed us to do within the young people living with type 1 diabetes was it built trust. It improved the relevance of the work that was being done, but it also sped up some of the translation because those young people went back into their communities and were able to talk confidently about what does stem cell derived cell therapies for type 1 diabetes actually mean, and what does it mean from a lay perspective of someone that lives with type 1 diabetes who may not have a science background. What does that actually mean for me, or what does that mean for someone else who might live with type 1 diabetes, and where the research in diabetes may be in 20 years time, and what potentially might be available to me as I get older. So it was really important to those young people that they were part of that process and part of understanding how that research worked. But similarly for the young scientists, it gave them motivation to keep doing what they were doing and to continue asking research questions and to continue work into diabetes. And so we wanted to highlight that as an example of how patient or lived experience involvement in projects like this can be really beneficial to both sides of the project team. So I think I'm going to hand back over to Hilda now for the last few slides.
Thank you so much, Cameron. And this will be also a nice transition to my section on evaluation criteria. And this is how important it is to also involve patients and patient organizations to build a competitive proposal. So you are probably quite familiar with the three criteria here: excellence, impact, and implementation. But I wanted to give some examples what it could mean for diabetes projects. So in excellence, you really should ask yourself if the science is strong, innovative, and well-grounded. And here you have the chance to position diabetes as a complex systemic disease, make sure that the innovation is really beyond state of the art, and also emphasize the human relevance and use the cohorts, registries, and biobanks and real-world evidence. In terms of impact, you want to ask yourself, will this matter beyond the project lifetime? So make sure that you have or position this clear contribution of the project that is also aligned with the EU health priorities, the involvement of the patient and patient organizations, and how this project can help reduce complications, for example, cardiovascular disease or kidney disease. In implementation, you want to ask yourself, can this consortium actually deliver? So is it complementary and a credible consortium? Is the plan realistic? Have we accounted for risks and have a proper risk management? And have we done a proper budgeting that is reasonable and feasible within the time of the project? It's also important that not only for the research and innovation to have the gender aspect, but also in terms of building the consortium. So making sure we have a balance in the partners and the PIs that are involved in the project. In the last, I will go more into specifics on building a competitive proposal. So in terms of just general writing tips for strong proposals, make sure that you carefully read the instructions and the guidelines and take some time before starting to write and really think and discuss and work together with the partners to make sure that you are aligned, and this will help to make the proposal clear and coherent. The scientific goals should really be matched with the call expectations. Again, I'm hammering it in, but involve the individuals with lived experience and patient organizations early on, already when you're starting to think about the project and the goals of the project. I mentioned the excellence, impact, and implementation focus, but really, how can this project fill the gap and go beyond state of the art? So to summarize a checklist, make sure the topic relevance, the idea is clearly aligned with expected outcomes. Make sure you have a strong consortium with partners from at least 3 eligible countries with complementary strengths to make sure that this consortium is uniquely positioned. Make sure you have the experience and the capacity that either you or your partners have the EU project experience or the ability to manage one. And the last one, in terms of timeline and budget, can it be realistically done? There's quite often a little bit over ambitious project within the time frame of 4 to 5 years, depending on the projects. So in terms of next step, we really encourage you to look over the work program to identify relevant calls for you. We also wanted to share that there's an info day organized by the European Commission on the Cluster 1 health. But there's also a brokerage event that is online that really gives time for potential applicants to connect with partners and help to prepare a strong proposal. So with that, I will hand over to Sabine that will summarize today.
Thank you very much, Ilda, and thank you very much to both of you for providing such a very clear and comprehensive overview of what makes a good proposal. Before I summarize the key takeaways, and before we move to questions and answers, please feel free to ask any questions that you have in the chat or the Q&A. And of course, you'll also be welcome to raise your hand when we get to the question and answer sessions. So I think that we've heard very clearly that involving lived experience is key to making a project a success. And as Cameron explained, this can take a huge number of different forms. So don't just also include lived experience as a tick box exercise. Really think about what the involvement will look like, and actually, better still, get people with lived experience involved from the inception, from the moment when the project is being developed, during the writing of the proposal, to make sure that you have considered all angles. Of course, the scientific goals must align with expectations. So again, think about what can I bring to this project and how is it going to be implemented. And excellence, impact, and implementation, these are key sections in a call, so they must be considered very carefully. And so is the consortium. I think that it is vital to have as many meetings as you can to together define how the various bits are going to fit together, because of course we can have a number of different components, but to make it a compelling proposal, we have to see what the interplays are going to be. So that really helps define what each participant will do and will bring and how it all fits together. And of course, the reason we're having this webinar is to make sure that we are here to answer any questions that you may have. So please feel free to reach out to us after the webinar if you want to know more about applying for one of those calls. So I think we have come to the time to go through questions and answers. So I don't know, I'm going to look. I don't think that we have any questions in the chat or the Q&A that I can see. Would anybody like to ask any questions? Please feel free to raise your hand. Okay, I see a hand being raised. Would you like to come up and ask your question, Elizabeth?
And thank you everyone for the presentation. And I have a quick question about the broker event. Do you know how that works and what's the process of this?
For the brokerage event.
Yes.
Yes, so there is an online brokerage event, and I think there's also an opportunity to schedule like calls, like partnering calls. It's going on several days. We can maybe pull up the link. I can see if I can pull up the link again. The QR code here where you can find more information on this online event. And I can also see, sorry, Sabine, I can also see in the chat that our people are writing if there's interest also in any calls to reach out as well.
Yes, so I can see that Martina will be sharing information as well. I don't see any other questions that are open at the moment. Okay, so I see a question in the Q&A. So the question is, my 11-year-old son is living with type 1 diabetes. I'm looking at all these interesting initiatives from a fundraising perspective and saying if I want to support any of those, what's the best way to go about it? Don't know, Carmen or Hilda, if you have any suggestions about that.
Carmen?
Hello everyone. And in regards fundraising, this is just public fund from the European Commission, so it's not requiring fundraising. I'm aware that in Italy there is several organizations also working towards a cure of type 1 diabetes, so perhaps you can contact some of those foundations. But in terms of fundraising, this is not really open for fundraising, but something that you perhaps could do is just promote this cause so investigators are really aware of these opportunities, and they can really present a proposal towards a cure of type 1 diabetes.
Thank you, Carmen. And then in the chat, there is also a link in the Q&A about looking at the europa.eu info funding tenders and opportunities portal for anybody looking for general supports. And there you will find your national contact points where you can have a chat to see, what calls are available, how to go about applying for them. Thank you, Joe, for sharing that. So I don't see any other questions. So if there aren't any questions, we will be able to close the call now. And as I said, please feel free to contact us if you've got any questions whatsoever about the best way of applying or if you want to know anything. So thank you very much for attending this webinar, and the recording will be made available shortly. Thanks a lot.